So testing is divided here between a number of different features, right? We've got respiratory samples and serology, or blood tests, right? So the respiratory samples are going to be obtained from a number of different ways. The easiest, most rapid way of doing this for respiratory samples is not actually nasopharyngeal, but is just a sputum, right? Having somebody bring up some sputum and put that into a sample cup would be the easiest way to do it. The problem is that you just get so much saliva in that it's not a very good sample, and so therefore the testing characteristics are usually quite poor. Similarly, you could just swab somebody's cheek inside their mouth and do an oropharyngeal swab. That's easy and much easier to tolerate. But again, you get a bunch of saliva and a bunch of bacteria and other features that don't really allow you to have the same sensitivity to testing. So therefore, the swabs we're using are nasopharyngeal swabs to get into a space that has a higher sensitivity, but overall still does not have the same level of sensitivity as those samples from respiratory status that can be obtained, from bronchial or alveolar lavage. And so, that's impractical to imagine that we were going to bronch everybody and determine that. But when you actually look at studying the disease early on, you realize a disease that is mainly a lower respiratory tract disease has a much higher sensitivity and testing characteristics from samples from the lower respiratory tract than they do from the upper respiratory tract, like the nasopharynx. And then serology testing is really the testing for the presence of antibodies. It's not only that, though, of course, right? You can test for the specific quantitative amounts of virus that are present, and we see that in our usual practices when we're following patients with HIV and looking at what their viral loads are. In a disease like HIV, where the virus is sticking around much longer, that has a certain level of information that it really is helpful for, whereas when respiratory illnesses, the amount of virus that's present in the bloodstream is transient and is not expected to be necessarily a lifelong viral carrying of that disease. And so therefore the antibody testing is really what we're focused on. So I realize I'm just putting up two examples here, but just wanted to make certain that I was giving at least some attention to the different ways that this is done in terms of testing. So when you test, you're going to have a group of patients that are non-infected that have a certain frequency of that test. So in doing PCR testing, there's a bunch of different chemicals that are added together with a fluorescent marker and the ability to amplify the presence of those nucleotides. And so there's a counter that measures that. And so you're going to have some measurement of a tracer that's present in the sample. And so that's what this distribution shows. There's going to be, half the patients are going to be at a certain level, and then they're going to taper off on either side. And then those that are infected are going to have much higher counts, and therefore we're going to see differences between those curves, between those that are infected and those that aren't. And we need to pick at some point a cutoff. And so here that cutoff is decided, and it's 40 copies per a certain degree, a certain concentration. And after 40 cycles that occur, this presence of this much tracer is associated with defining who has the disease, and that's how we define that's how we make that determination with the PCR test. And so we create here with the COVID test that you can either be positive or negative on that test result. And this is patients are either going to have the disease or not have the disease. So you have that group here of COVID disease or no COVID. And what creates this 2x2 table. And so here I'm giving an example of when the prevalence is 1%, right? There's 100 cases that have COVID out of 10,000 cases that don't. And if a test is very sensitive, and this is a made up example here, 99 of the COVID tests COVID cases will be positive, and we'll have one false negative. And if the test is very specific, we'll make it equal specificity here of 99%. We'll have 9,900 cases that are negative out of 10,000, and you've got a very specific test. Now, what that does is in a low prevalence, it really affects the positive predictive value here, right? Because ultimately, all you got to see was that you had 199 test positive, and 100 of those were false positives. So your positive predictive value is only 50%. And that's because it's so affected by prevalence, as is the negative predictive value, right? The negative predictive value here is 99.9999%. And if we imagine this with just slightly different numbers, so we're going to increase this from 1% to 10%, we see here again, our sensitivity is not changing, and our specificity isn't changing. But now, with 10% of the cases being present, we've got 1,000 cases. And so now 990 of those are true positives, and 100 are only false positives. And so now our positive predictive value is increased to 90.8%. And the negative predictive value remains the same. So the prevalence alters, in particular, the positive predictive value early on in the process. And as the prevalence increases significantly enough, it will eventually affect the negative predictive value as well. So from an epidemiologic standpoint, we often don't focus too much on the positive predictive value or negative predictive value in screening because it's so affected by prevalence. Instead, the sensitivities and specificities are features that are unencumbered by the prevalence and are not features related to the prevalence, and therefore they're a more stable metric. And so it's why early on, when all of this started, we were getting a bunch of reports of who was testing positive with tests that were not being described by their sensitivity or specificity, and was causing a lot of confusion and concern. I'd reached out to a friend of mine that's involved with the health ministry at Singapore and involved with one of the first studies that came out of Singapore on COVID. I reached out to the head of infectious diseases at USC and initially asking them, do we know what the sensitivity and specificities of these tests are? And the initial answers were no, we don't know what they are. And so we were really kind of moving somewhat blindly and being able to try to figure out like what our disease burden was and what our prevalence was going to be, which is what created a great deal of fear. And now we're seeing reports come out following this, and we're going to get to that towards the end. But we're realizing now that in many cases early on, the sensitivities were really quite poor. And there are a number of different reports that indicate that sensitivities could be as low as 30% to 50%. When those initial reports came out, I was reluctant to share that with anybody because it just would add more fear to a situation that wasn't going to be approved upon until we had more testing done and more metrics that could be done to characterize it. So when we look at these sensitivities and specificities, though, again, they're limited. These are descriptive statistics, and so they're describing some aspects about the test, but they don't fully inform you about a test, and they don't really tell you a lot about is a test diagnostic or not. In this example, I'm using a very extreme example that's not typically seen, where both the test is both 99% sensitive and 99% specific. That's a fantasy test that everybody would love to create and sell. But often we have just one feature being higher than the other, and more often than not, both are just moderate in terms of their ability, meaning there's only moderate sensitivity or moderate specificity. And what really matters in making decisions and determining whether or not a test should be used for diagnosis, in particular, is the likelihood of a positive test result indicating that the disease is present, or the likelihood that a negative test result indicates that the disease is absent. And so that's referred to as likelihood ratios, right? It's a fraction. And this is always the part that I always get concerned about whenever I'm giving any sort of presentation like this, is I know that I'm presenting math and I'm presenting fractions. And in particular, in my own family, fractions are a feared mathematical concept still. And so it's one of those things that I don't want to turn you off from this, but it's important to understand that we have a way of defining a very important fraction that makes a difference in the way that we think about medicine, the way that we think about a diagnosis. And so if I'm applying a test, I'm applying that test because I don't know if somebody has something or not, and I need that test result to help sway me in one direction or the other in terms of supporting my decision that they have the disease, or refuting that they don't have that, and moving on to additional testing or other additional strategies to figure out what's wrong with the patient, right? So the positive likelihood ratio is just the sensitivity divided by 1 minus the specificity, which is the false positive rate. Right? So sensitivity divided by the false positive rate gives you the positive likelihood ratio, meaning that if a test is positive, this is the likelihood that the patient actually has the disease. And this is not affected by prevalence. Right? The positive likelihood ratio as a metric is unaffected by the prevalence, and that's why it's an important feature, because it doesn't change and shift on you like the positive predictive value or negative predictive value did before. Similarly, a negative likelihood ratio is that the likelihood that somebody doesn't have the disease or test negative and doesn't have the disease, right? So we're going to take the false negatives, so 1 minus the sensitivity divided by the fraction of the specificity, and that's going to give us a fraction of a number that's less than 1. So likelihood ratios give you a fraction that's 1 or greater. Negative likelihood ratios give you a fraction less than 1, right? So a number between 0 and 1 is going to be where negative likelihood ratios live. We won't get into this too much, but there is another concept to be able to compare tests to each other, which is the diagnostic odds ratio. And that's where you do a ratio between positive likelihood and negative likelihood. And these numbers can get really big, so sometimes they're transformed by a log base to figure that out. I won't go into that further. So here's what happens early on in a disease like COVID, is you've got this large portion, this huge portion of the population that's unaffected, and this very small portion of the population that is infected, and you're applying a test to that. And so in this example, you've got a fraction of basically here 1/10 of a percent. And the sensitivity of our fake test is still going to be there, 99%. And we're going to have a specificity that's really high at 97.5%. And you realize here the positive predictive value is only 3%, because the overwhelming majority of those that tested positive were actually false positives, because the testing feature wasn't sufficient enough to differentiate the two. And again, this is where the positive predictive value is a problem. And obviously, again, the negative predictive value, the test could be a shitty test and have a ton of false negatives, and your negative predictive value won't be affected because the prevalence is so low. So no matter how shitty the test is, it can miss, it could only get 1 out of 100 cases, and 99 are missed, and your negative predictive value is still 99.9% because you have so few in the population that have the disease. And unfortunately, when a pattern like this, this is a predictable pattern, right? This is expected. But as we go through this with the lay public, this is a feature that many people will use or can use to seed a distrust in the healthcare system and in the scientists that are involved in this, because these numbers are not very informative in that way.